Hello guys, today we're going to have another comprehensive BSc review for you. I'll try to keep it short today for 15 minutes. I'll try to cover as much as high yield conditions that I think are important for you to know. So please email me if you had any questions. The first one is bullous pemphigoid, which is because of damaged hemidesmosomes, and you have large blisters that do not rupture easily. So that's the first condition. Then we have pemphigus vulgaris. It's because of damaged desmosomes. You have blisters that do rupture, and also we see Nikolsky's sign here. The GERD is a reflux disease due to weakened lower esophageal sphincter, can result in Barrett's esophagus. Also, we have metaplasia of stratified squamous epithelium to simple columnar, because as you know, the normal epithelium of esophagus is simple squamous, and if there's too much acid reflux, that can trigger it to be simple columnar. In sickle cell anemia, it's a mutation of glutamate to valine on beta globin gene in position 6. Therefore, we have less negative hemoglobin, and the hemoglobin moves slower. The hemoglobin S moves slower than hemoglobin A, and it will move toward the positive electrolyte. And they have heterozygous advantage in areas with malaria. Cystic fibrosis is the most common mutation in location 508, deletion of phenylalanine. So the phenylalanine is deleted. It's a mutation in ATP binding domain of ABCCFTR channel. So therefore, it cannot translocate to the cytoplasm, and it allows for flux of chloride, and it cannot basically allow for flux of chloride. The mutant CFTR channel, we can have it in the lung, GI, liver, and pancreas, and in all of those, we will have decreased chloride secretion that can have different symptoms in each organ. The mutant CFTR channel in the skin can cause salty sweat that we can test it with pilocarpine. The Cartagener syndrome is a mutation in dyning. The cilia is abnormal. We can get recurrent respiratory infection, male infertility, high risk ectopic pregnancy, and dextrocardia. SCID is a problem with immunity because there is a mutation in adenosine deaminase. Therefore, we have our ribonucleotide reductase function inhibited, so we cannot form DNA. Therefore, our immune cells, lymphocytes, they cannot divide very well. Therefore, we can get recurrent severe infection. And in ataxia telangiectasia or Lewis-Barr syndrome, it's the ATM mutation, inability to perform non-homologous end joining, causes degeneration of Purkinje cells in the cerebellum. So basically, it's a cerebellum issue, causes ataxia, delayed motor skills, and they are usually wheelchair bound, and they might have telangiectasis on the ears and eyes. They're also prone to cancer because of the loss of cell cycle regulation. The familiar hypercholesterolemia is a type 2A hypercholesterolemia. It's a mutation in LDL receptor, increased LDL. We have formation of foam cells, and we can get xanthoma and xanthelasma. Achondroplasia is a mutation in FGFR3 gene, which causes premature ossification of epiphyseal plate in the bone. Neurofibromatosis is a autosomal dominant mutation in NF1 gene. NF1 gene is a tumor suppressor gene. And if we have this type of mutation, we have loss of regulation of RAS GTPase. And therefore, we have constitutively active oncogene, which causes cancer. Some of the symptoms is cafe au lait spots, neurofibroma, optic glioma, and list nodules. We also can have allelic heterogeneity in this condition. It has high penetrance, but variable expressivity. In the Huntington disease, it's a triplet expansion of CA gene exon of HTT gene. It's polyglutamine tract expansion. Some of the symptoms are chorea, dementia, sleep disturbance, ex-vacuo hydrocephalus. So it's an example of anticipation, which is a condition where it gets worse over time. Myotonic dystrophy is another triplet expansion disorder with which occurs in the DMPK gene. We have myotonia, loss of facial expression, weakness, cataracts, cardiac conduction problems, testicular atrophy, and it's again another example of anticipation. OI mutation in COLA1A and collagen 2A, we have displaced glycine, and that causes basically blue sclera, conductive hearing defects, bone fractures. In Ehlers-Danlos syndrome, that's a collagen type 5 mutation that would cause hyperextensibility of joints and the skin. Also can cause hemorrhage problems. That's because it has a vascular form of it, which can affect type 3 collagen, and in that case, it can cause a hemorrhage and then death due to hypovolemic shock. We have Marfan syndrome. Marfan syndrome is a mutation in fibrin 1 mutation. It's important for you to know that they don't have any problem with elastin, and they might have pectus excavatum, achondrodactyly, aortic root aneurysm, and they're usually very tall. They have long, thin limbs, and they also might have mitral valve prolapse. It's also a dominant negative. Alpha-1 antitrypsin mutation or an alpha-1 antitrypsin deficiency is a condition where they have too much or overactivity of the elastase enzyme. As you know, antitrypsin is a protein that normally will inhibit elastase. So if that is mutated, elastase will be overactive, and therefore that would cause elastase to basically eat up the alveolar wall, and that would cause emphysema. And the emphysema is a condition where we have air trapping due to degradation of the alveolar wall. The next condition is Duchenne muscular dystrophy. We have frameshift mutation, no production of dystrophin, so there is no production of dystrophin. It's not that the dystrophin is like truncated. In the case of Becker's, it's just like we don't have any production. And we have kids with positive Gower sign, muscle wasting, calf pseudohypertrophy. They usually die early, and more importantly, it's a X-linked mutation. They don't have any reproductive fitness because, of course, they don't even live long enough to be able to reproduce. And we don't see any dystrophin neither in immunofluorescence or Western blot. Becker muscular dystrophy is an in-frame mutation. In this case, we have the dystrophin, but the dystrophin is truncated. We see it in people who are 20 or 30 years old. They have central muscle weakness, loss of strength, and cardiac complications later in life. And normally, they have the normal reproductive fitness because they live long enough to be able to reproduce. The Fragile X is a triplet repeat expansion disorder. We have excessive methylation and silencing of FMR1 gene. They have long face, intellectual disability, autism-like mutation symptoms, and they have prominent ears and macro childism. And as we said, it's a overproduction of, in the FX test, it's a kind of prematuration, and we have overproduction of FMR1. Chronic granulomatous disease is super important. It's NADPH oxidase deficiency, the neutrophils and macrophages, as you know, in order to be able to kill and eat up the bacteria, they need to produce ROS and bleach. So in the case of chronic granulomatous disease, they need to use the NADPH oxidase enzyme to be able to produce the ROS and the bleach, and to be able to do the oxidative burst and kill the bacteria. So when this enzyme is deficient, they're not able to kill the bacteria, so there's no intercellular killing, and therefore we have formation of granuloma and recurrent bacterial or fungal infections. Next condition is the myeloperoxidase deficiency, is lack of HOCl in phagolysosome, and mostly they have fungal. There is less destruction of fungal, so they can get recurrent fungal infection with Candida albicans. One of the conditions that Candida can cause is oral thrush. That's all of you might have heard. G6PD is deficiency. They cannot form any NADPH at all in the pentose phosphate pathway. And as you know, we need the NADPH to be able to have our glutathione pool. So therefore, they have reduced glutathione pool and reduced detoxification of the hydrogen peroxide. Therefore, we have too much of the hydrogen peroxide and other ROS building up into the cell. We have increased oxidative stress, and that would cause the cell to lyse and die. One buzzword for it is Haynes bodies. And it's an X-linked mutation. So I'll stop the session now, but I'll try to continue and cover the rest of the stuff in our next session. Please let me know if you have any questions. You can always email me if you need clarification on any concept. Thank you so much for watching this video.